We are so delighted to welcome Dr. Catharina Lindberg. Thank you so much for coming.
Oh, thank you very much. Nice to be here.
Then could you please introduce yourself?
Well, my name is Catharina Lindberg. I live in Sweden, and my background is that I became a registered nurse in 1985. And after a few years of work in different hospital wards, I wanted to specialize. So I did some studies, and I became an intensive care nurse. And then I worked in different ICUs for about 20 years. And then in 2006, I went back to university to study educational science and became a registered nurse teacher. And then I graduated with a master in educational science and started to work at the university, which I'm still doing then. And then I wanted to learn more about nursing and research. So I continued to study and finished my PhD in nursing in 2016. And now I work as a senior lecturer and researcher in caring science at Linnaeus University. And since 2018, I'm honored to be a member of the ethical board of the Swedish Nurse Association. And I'm also a member of the international steering group working with the revision of the International Code of Ethics for Nurses. However, the work is at hold at the moment due to the pandemic.
You have rich experience both in practice and research, so I really appreciate it. Then could you tell us your research interest?
Well, the topic for my thesis was about patient autonomy in highly technological care environments from a caring perspective. And it has like three constituents that I still think is of interest to me. And first is the ethical concept of autonomy. And I think it's interesting in relation to the role of being a patient. And second, it's the high-tech care environment that involves both care in ICUs, emergency departments, pre-hospital care, etc., and also advanced home care. And the third is the patient perspective of care that I embrace, and beyond the concept of patient autonomy, I also find interest in other concepts like participation, partnership, person-centeredness, etc. I also have research interest in patient self-care, and I'm involved in studies of this concept of self-care related to self-care monitoring, and of studies of self-care related to difficult to heal wounds, and also to studies of self-care interventions. And finally, then I'm involved in studies of integrated care and care continuity related to care planning and effectuating care transitions between the hospital and the home setting, involving both perspective of personnel and patient.
Thank you. So I'm curious to know more about your talk. So if you're okay, then could you please start your presentation?
So first of all, I want to say thank you to Professor Teshima at Chiba University in Japan for inviting me to have this talk about nursing challenges related to our profession and to the patients that we care for and about. I've chosen to talk a little about nursing theory and the concept of patient autonomy. As we all know, nursing science started with Florence Nightingale, and her work started out the first scientific revolution of nursing. And the second revolution of nursing started with Martha Rogers from the United States. And she stated that, and made clear that the scientific part of nurses' work is about three things. It's about the ontology, how we as nurses look at the world and at human beings. It's about epistemology, how we as nurses look on knowledge. And it's also about methodology, how we as nurses produce new and reliable knowledge. She thought it was important to have a scientific language in nursing, and the language of nursing evolves from the studies of concepts and nursing theories. And as nurses, we need to know what we mean when we use different concepts, as concepts has a substantial content and a deeper meaning. They are not just words. So first, I would briefly like to address some of the Nordic nursing theorists, and then I will move on and talk about one of my great interests, patient autonomy. These Nordic nursing theories all have their foundation in the concept and tradition of caring. And I will start in Norway with Kari Magnussen and her theory of philosophy of caring. Her theory has a philosophical foundation, and through her theoretical lens, care is about someone's life and well-being through mercy. She's inspired by the Danish philosopher Løgstrup, who wrote about the interdependence, that is, the mutual dependence between two persons, in this case, the nurse and the patient, and its importance in the care relationship. We then go to Iceland and to Sigriður Halldórsdóttir and her theory, Caring and Uncaring Encounters in Nursing and Healthcare. Her theory shows that a carer can be, for example, either a bridge or a wall in a care encounter. The nurse needs caring competence. She needs to be open and sensitive to the patient's needs and wishes, and otherwise there is a risk of distancing and that the encounter becomes an uncaring encounter. In Sweden, we have, among others, the theorists Karin Dahlberg and Kerstin Segersten, and their theory of health and caring. This theory has its foundation in life-well phenomenology, and it is expressed that from its existential perspective, a person is in a situation of freedom and vulnerability at the same time. And this theory highlights concepts like viability, meaning of life, and rhythm of life. And finally, we go to Finland and to Katie Eriksson, who died in 2019, and to her theory of caritative caring. Her theory has a Christian foundation, and she looks at ethos as the core of caring. She says that caring in practice is, according to her, then about tending, playing, and learning. She also lifts concepts like faith, hope, and love as important tools in caring. And she also wrote a lot about suffering, which she divides in suffering from illness, suffering from care, and suffering from life. I would like to share this model from Katie Eriksson with you, because I think it's interesting. She called it caring as a theoretical, practical, and ethical moral occupation. And she thought of caring as an intellectual work. So nurses use its theoretical knowledge in their daily work, that will say the head. And then she says that caring emanates from the will to do good, which is the heart. And then finally, caring is effectuated as a skillful handcraft where the craft and the result shall be aesthetically appealing, which is the hands then. So I like her vision of caring with the head, heart, and hand, as it shows the need of multiple skills to handle the complexity of nursing. So why patient autonomy? Well, as you can see, a lot of nursing theories have an ethical component, and I became interested in the ethical concept of patient autonomy when I was doing my studies in educational science and moved in and out from my work as an intensive care nurse. I found that there was a lack of consistent view about the concept patient autonomy within the field of nursing and caring. I also found that there was a lack of knowledge about the phenomenon patient autonomy in high-tech care environments from the patient's perspective. And also that patient autonomy and high-tech care is partly contradictory. That is, on the one hand, the high-tech care environment is demanding, and to manage it, you need specific knowledge. And on the other hand, the patient in need of high-tech care is usually severe ill and vulnerable. So I decided to look into this complex concept of patient autonomy from a caring perspective, and I performed a concept analysis of 41 previously published studies on the subject. I found that the challenge that addressed patient autonomy, the so-called antecedent, was an increased vulnerability, which had to do with a changed interdependence. That will be the mutual dependence between two persons, in this case the carer and the patient, or a need of care support. I also identified 5 attributes that describe the concept, which are put on the line to the left in the picture. And from these attributes, I created a descriptive definition, which says then, patient autonomy is a gradual, time-changing process of reconstructing autonomy through the interplay of to be seen as a person, the capacity to act, and the obligation to take responsibility for one's actions. The consequences then of patient autonomy were shown to be preserving control and preserving freedom. I chose high-tech care environments to continue my studies, and a high-tech care environment is a special care environment where the patient is connected to a large amount of electronic monitoring equipment and sometimes also to life-supportive medical technology. And to work there requires specific knowledge about care and also specific knowledge to make decisions about care. I chose to study 2 high-tech care environments, the ICU, as this is an environment that has been high-tech intense for quite a long time, and then advanced home care, as we believe that more and more complex care will be distributed at home in the future. This is a schematic overview of the findings from an interview study with patients that had been treated in the ICU. And the overall theme turned out to be that patient autonomy in the ICU is a trajectory towards partnership in care, depending on state of health and mutual understanding. And this trajectory is not a linear path, but you can say that it is a path from being dependent to the left and being independent to the right. And you can, as a severely ill patient, you can move between those boxes, as you see here, and you can also move inside them, so to say. So it's about acknowledged dependent, it's about being recognized as a person, to be invited to participate, and also becoming a partner in care. So what we can see is important is both the state of health of the person and also the mutual understanding between the patient and the carer. If we then look into patient autonomy in advanced home care, it was expressed by the patients as befriending everyday life when bringing technology into the private sphere, which means that they had to become friends with a new way of living, as they did not have any other choice. They talked a lot about befriending the lived body, and they said that their body set the boundaries for the life with technology by means that their illness was the limit and that controlled their life. And at the same time, the technology offered a great independence when the body so allowed. So it was the body itself who was the limit to life, not the technology. They also talked a lot about depending on good relationships, and they said that the family provided a large support to be able to handle the illness in a positive way, and therefore the technology exerted an influence not only on the participants themselves, but also on the everyday life of the whole family. They felt that it was important to keep the home as a private sphere, and that was challenged by the use of advanced medical technology, and the technical equipment changed its physical environment, which they didn't like then always. They also talked about managing the time, and some participants performed nighttime treatment as a prerequisite for daytime activities. For example, they had dialysis during night to be able to go to work and to leave their kids at school during the day. I then synthesized my findings into a framework of patient autonomy in high-tech care that I called the Control Partnership Transition Framework. And it is constituted of the three prerequisites with its strategies used by patients to try to attain autonomy in the role of patient. The strategy of control refers to the prerequisite preserving or surrendering control of everyday life. And then there are two strategies, the strategy of partnership and the strategy of trust, that refers to the prerequisite co-determination through partnership in care. And finally, the strategy of transition, that refers to the prerequisite transition in everyday life to depending on others and the environment. So what can we say then about patient autonomy in high-tech care? We can say that patient autonomy is not an absolute and does not need to be the same before, during, and after a care episode. We can also say that it is important that the power is divided between patients and healthcare personnel in high-tech care environments, preferably by co-determination. And patient autonomy in high-tech care environments requires a transition of the view of the patient from a vulnerable person to a capable person. And lastly, then, person-centered care can be an important prerequisite for patient autonomy in high-tech care environments. And then I made a take-home message for you. And first, I would like to say congratulations. To be a nurse is a fantastic occupation. You get the opportunity to all these encounters with others that include joy and grief and everything in between. When you work as a nurse, try to look at the patient as a partner in care and as a capable person, maybe not completely capable to do everything, but most often capable to some extent. Don't forget to invite the patient in decisions about his or her care, as being involved also can help the patient to heal. And finally, care with your head, your heart, and your hand, so that the patient gets professional care based on evidence, on ethical judgments, and good practical skills. Thank you.